Continuing on with our discussion of OB-GYN concerns, any questions from Tuesday's lecture? Anything at all? You guys know how to manage pregnant patients? I found the best thing to do is just be quiet. Don't talk as much as possible. That usually kept me out of trouble. The few times I did, it was bad. So anywho, so we're going to continue on. We're talking about estrogens and we'll talk about progestins. We're talking about clinical uses of estrogens. So we can also see it used for primary hypogonadism. So you can replace patients who are deficient in this on their own. So, you know, if they have developmental failures of the ovaries, they have premature menopause, castration, anything like that, you could use this to help replace that. So this is kind of going into that hormonal replacement therapy, which we'll talk more about in details a little bit later. So you can see where you'll give it, you know, right around where puberty would normally occur, say 11 to 13 years. And this will help to kind of develop secondary sex organs. It will help to help prevent things like osteoporosis and whatnot, because we know that estrogens have those positive effects on the bone. And then you'll kind of give it like a normal cycle. So you'd give estrogen, say, day 1 through 21 to help kind of replicate what the female would normally be experiencing otherwise. And then you'll also add on progestin after the first uterine bleeding. That way you can make sure that the progestin's there to kind of help deal with the endometrium. Because again, as we said, the more you have kind of contested estrogen effects, you're just going to keep developing that endometrium. That progestin's there to kind of help get rid of that. And then this will probably be one of the bigger places you'll use your estrogens for postmenopausal hormonal therapy. This is for women who have lost their menstrual periods, if they're having significant vasomotor symptoms, sleep disturbances, genital atrophy. These are all places where these estrogens can kind of help with this. Also, because they're having accelerated loss of bone, the estrogens can help with this as well. So this is useful for vertebral, hip, and wrist fractures to help prevent this. And then we can also see that when women lose the ability to produce a lot of estrogen, you're going to have changes in lipids, and this is thought to lead to some atherosclerotic changes. So if you kind of go back to your hyperlipidemia lectures to read up about that. But anyway, we see that LDL is increasing. We know that the receptors themselves help to get rid of LDL are decreasing on the liver. And so for a while, it was thought that estrogens were thought to be cardioprotective, but the literature is kind of plus minus on that. So it's hard to say whether or not you're really getting a whole lot of bang for your buck by replacing this. But you also have to weigh it against things like possible increase in breast cancer risk and whatnot, because the more you're hitting those estrogen receptors in the breast tissue, the more likely you are to develop breast cancer. So you really need to consider all aspects of your patient. You have to look at their cardiovascular risk, osteoporosis, breast cancer, endometrial cancer risk factors. You'll see that the type of product you're going to use is going to be dependent on a lot of these factors. So obviously, if we can use products that have topical administration or just local administration, this is going to help to reduce the amount of systemic effects that they're going to get. So you're going to be better off to avoid a lot of those potential side effects. And so you also want to use the lowest dose possible to help reduce those symptoms. So, if they're getting hot flashes, that's really their main concern. Use the lowest dose possible in order to help deal with that, because otherwise you might run into risk of some of these other adverse effects popping up. For those patients who have had a hysterectomy, you don't need to add progestins on. They can just use estrogens alone, because you don't really have to worry about that endometrial cancer risk for those patients. So that's an important thing to remember. Whether or not they have a uterus intact, that determines whether or not you're going to need a progestin added on. Does that make sense why that is? Okay. I see the women shaking their head. Hope the guys get it too. Yeah. Okay. And then, so you'll also see it being utilized to help prevent osteoporosis, so this can also help to treat it as well. Again, you need to make sure your patients are also getting adequate calcium, vitamin D intake. Also, exercise is very useful to help kind of stave off osteoporosis. You see frequently that it's usually thin, Caucasian smokers who are fairly inactive who end up having kind of the highest risk for this. And we know that once you have something like a hip fracture or a vertebral fracture, that's a huge impact on doing your activities of daily living, quality of life suffers, huge risk for subsequent morbidity and mortality. So we'd like to prevent that as much as we can. And then you'll see that for if patients are just having something like atropic vaginitis alone, topical products can be useful for this as well. So using local therapy if they're only having kind of local symptoms. You can also utilize estrogens for ovulation suppression if they were having intractable dysmenorrhea. That's one possible use. We can also see suppression of ovarian function. And also if you're having something like hirsutism due to excessive androgen secretion, this can help to treat that as well. So several uses for estrogens. So looking at the adverse effects of using estrogens, we kind of alluded to some of these already. Certainly uterine bleeding is going to be a very common side effect, and so this can be probably a pretty major cause for most postmenopausal women. Could also be due to endometrial carcinoma. So that's one of those things, if you're having abnormal bleeding, probably should get checked out first. To limit this, you can use the lowest dose of estrogens possible. So that's one way to do that. And then you can also give estrogen cyclically in order to help establish kind of a normal cycle. So during the withdrawal period, that's when you would end up having the bleeding during that period. So we'll look at some of the different products and how some of them are going to be continuously administered estrogen. Some of them will be more cyclic, where you would get estrogen, say, on day 1 through 21, and then you have nothing for the rest of the 28-day period, basically. And so if they do have an intact uterus, we can give progestins as well to help limit the amount of endometrial hyperplasia you have there. So we'll look at the different products and how those kind of stack up to one another. So the cancer risk, we see that certainly with prolonged use, you have increased breast cancer risk. Adding on a progestin does not decrease this risk. So that's one important point to consider there. And we'll talk about some drugs called SERMs, or selective estrogen receptor modulators. Those are going to be later on in the lecture. Those can be used for high-risk patients. So do you guys know what SERMs are? So can anyone describe it for me?
It acts as estrogen in some parts of your body, but it doesn't put the same receptor, fire the same receptors in other parts of your body?
Basically, yeah. So it acts as an agonist in some tissues, but maybe act as an antagonist in other tissues. So we'll see where some of the drugs, some of the SERMs are going to act as agonists, say, in the bone, but they'll act as an antagonist in the breast tissue, right? And that goes back to those different steroid receptors that we mentioned there in the nucleus. So based on kind of the morphology of those receptors, they'll respond differently to some of these drugs. And so say you had a high-risk patient for breast cancer, and they also had osteoporosis, you could utilize one of these drugs to end up mitigating that breast cancer risk, but having positive effects on the bone. So we'll talk about those a little bit later on in the lecture. So also, endometrial carcinoma, we give progestins for patients who still have a uterus intact to help prevent that. And then we will see also this kind of interesting thing, this adenocarcinoma that was developing in young women. This is actually linked back to maternal use of diethylstilbestrol. DES is the other way you'll see that commonly being referred to. This was an interesting thing where you saw this adenocarcinoma in these young women. They couldn't really figure out what the exposure was. We kind of talked about this a little bit probably in biostats and epidemiology, but essentially they were able to link it back based on maternal exposure to say, okay, well, this was the common factor here, to say this is what was causing it. So diethylstilbestrol was taken off the market and it's not available any longer.
Is it a part of a drug, or is it like something in the environment?
It was part of a drug. Like the females were receiving this as kind of an estrogen substitute. Yeah. Other adverse effects you can see, nausea, vomiting. You can see certainly breast tenderness. This is just due to the agonist effect that the estrogens will have on that tissue. You can actually see some hyperpigmentation that can occur, especially in more dark-skinned patients. Some of this can be reversed if you take away the drug effect, but some of it may be more permanent the longer the patients are on it. You also worry about things like cholestasis. How do you think you could prevent cholestasis from occurring? If you have to give an estrogen product. So you could possibly give it by a different route, right? So again, that's where we're talking about giving things locally in order to help limit those kind of systemic symptoms. So again, when estrogens are being processed through the liver, that's when you're going to see more of that metabolism occurring. That's where you see the drug being conjugated and spit out through the biliary tract. So if I gave something just locally, say if I were to give, say, a vaginal gel, if I were to give one of those rings that only acts locally, you end up preventing a lot of those symptoms, right? So orally administered medications, first organ they're really going to hit after being absorbed is the liver. So you're going to be seeing more risk for those side effects when giving things orally versus giving something, say, transdermally. So just keep that in mind. Look at those risk factors for your patients and whether or not that's going to be a potential problem for them. Certainly see some hypertension. This may be related to some of the kind of mineralocorticoid effects, kind of retaining some more water and salt. And again, to prevent some of these, you can help to use the lowest dose as possible. Some contraindications, so if they had an estrogen-dependent neoplasm, like breast cancer, you'd want to avoid these medications. Any kind of undiagnosed genital bleeding, because this could be cancerous in nature, you want to take care of that. Potential liver disease, again, that may be kind of relative contraindication if you're using a locally acting product. They have a thromboembolic disorder, so if they have kind of hypercoagulable state, this may be one thing to avoid, because we know this is going to help to upregulate clotting factors within the liver. And then also heavy smokers, because again, they're going to be a high risk for clots and also osteoporosis and things like that. So then on the flip side, you have your progestions. We know that progesterone is going to be the most important one that humans are producing. This can act as a precursor to estrogens, androgens, and also adrenocortical steroids. This is important because we're going to see that a lot of the progestions that we give are going to have some activity at both androgen receptors and also mineralocorticoid receptors, right? So that's going to be leading to a lot of the side effects we see when we're giving these progestions. And so we'll see that the synthetic ones that we're giving are going to have high variability in their physiologic effects between how they interact with androgen receptors. Some of them will be agonists, some will be antagonists. Also the same thing with the mineralocorticoid receptor. So just realize that there's going to be a lot more variability that you see in that versus with the estrogens, where they all basically act very similar to one another. Just really a degree of potency between them. So the historical problem, as I mentioned here, is this interaction with other receptors and just with progestin receptors. Here are the very common ones that you're going to be seeing used. If you ever looked at like different forms of birth control, you've probably seen a lot of these already. So norgestrel, levonorgestrel, obviously that's just the left-handed version of norgestrel. Norethindrone, drospirenone is probably a pretty common, a very popular one nowadays. And just be aware of the difference in activity and be aware of the side effects that can pop up based on the receptor activity. So if you imagine if you had something like norgestrel on board, has high androgen receptor activity, what type of side effects do you think you might expect from that?
Like flushing and sleep.
Maybe some flushing. I heard hair growth, I think. Like that's hirsutism could be a potential problem with that. And again, you typically don't want to have excess androgen effects in the females, because we're talking about those side effects in just a little bit. What do you think about high activity at, say, a mineralocorticoid receptor? What do you think that would cause? Possibly hyperpigmentation, but more fluid retention is what you're going to see. So weight gain could be another possible effect there. So this is where we see that something like drospirenone, which is in common products like Yasmin, things like that, those are useful because usually during a girl's period, like they're worried, they have weight gain anyway. This can actually be something where it has a little bit of a diuretic effect almost, where it actually may have a little bit of weight loss, and it has anti-androgen receptor activity. So this is the reason why that one is kind of popular. So just be aware of the different activity here, and be aware how that can affect the side effects that the females might be experiencing. So as far as pharmacokinetics, nothing too interesting here with the progestions. Note we don't have a whole lot of hepatic effects because this doesn't really get metabolized through the liver, mostly just gets excreted in the urine, so you don't have to worry about things like cholestasis. You also don't have that enterohepatic recirculation effect that you would see with the estrogens. Again, their mechanisms are going to work very similar to what you saw with the estrogens. They're going to be getting into the nucleus of the cell and working on those progestin receptors, and there they can start to increase or decrease transcription of different proteins and things like that to cause their physiologic effects. So what type of effects are we talking about here? So they're going to have little effects on the lipids, so you don't really get any kind of cardioprotection from administering these drugs. You can possibly see some increased basal insulin levels and insulin response to glucose, so you may have some positive effects there, affecting glycemic control. You'll also see, and this is where a lot of the mineralocorticoid effects are coming about, is it will compete with aldosterone in the kidney, leading to some increased release of aldosterone, right? So if the receptors feel like they're not really getting enough aldosterone activity, they're going to release more aldosterone. And what do we know that aldosterone does? Yeah, it helps to increase blood pressure, raises, retains more water to kind of fill the intravascular space. Perfect. You can also see it'll cause the maturation and secretory changes in the endometrium. That's why you saw that progesterone increase towards the end of the cycle, because it's helping to slough off the endometrium to get ready for the new cycle. And so we'll see that the synthetic agents, some of these are used to help reduce some of the side effects, and hopefully have as minimal androgenic effects as possible on the patients. So where do we use these? Mostly you're going to see it used in hormone replacement therapy. This will be for, especially for postmenopausal women who still have a uterus intact. This would be useful for them. And then you can also use it for long-term ovarian suppression. So you can see these being used, say, as a high-dose agent used by itself to prevent ovulation as like an intramuscular dose. This is where you get like your Depo-Proveras and things like that, which we'll talk about. So that one is given as an intramuscular product that's given once every 90 days. And so basically it's a kind of a long-acting drug that you just get once every 3 months that kind of helps prevent ovarian function. So again, when you give that, you're going to be seeing prolonged anovulation and also amenorrhea. This is going to be a problem when we're looking at patients who, when we're talking about oral contraceptives, or I guess contraceptives in general, that women who would like to get pregnant when they're using this product, we're going to see that's kind of a problem because the drug sticks around for so long. Yes? Answer yourself, okay. And so you will use this also if patients having dysmenorrhea, endometriosis, or bleeding disorders. If they can't receive an estrogen, oftentimes you can get away with giving one of these progestins because you really don't see the same kind of cancer risk or other side effects that you would see with the estrogens. So say, for instance, you had a patient who is, say, hypercoagulable, say they had some kind of factor issue that was leading to be more prone to having clots. You don't want to give an estrogen because that we know that would upregulate those factors. So instead, you can give a progestin that will not have the same effects. So, and again, keep in mind this is going to take longer for these patients to get back to a point where they can achieve normal ovulation, especially with these long-acting products. So again, if you have an idea of when you'd like to get pregnant, these are not good products for that because it can be variable how long it takes for the patient to get back on a normal cycle. Versus if you're taking like an oral product, it can be a little bit more consistent. Like you stop the drug and then maybe a cycle or two later you're kind of back on track. So we see adverse effects wise, it can increase blood pressure. We know that's from the mineralocorticoid effects and the aldosterone effects. And then we can also end up seeing that from the androgenic effects may actually cause some decreases in HDL, but probably don't have any big negative effects on cardiovascular risk. Okay, so getting into specifically hormone replacement therapy, we're going to talk about some of the different products that are available that can be used for this. So FDA-approved indications for using hormone replacement therapy. We can use these drugs for treatment of moderate to severe vasomotor symptoms associated with menopause. We can use it for atrophy. So if you're having dryness, dyspareunia, atrophic vaginitis, these are approved indications for these products. What type of products do you think you'd use for these symptoms specifically? Yeah, topical products like the creams or gels and things like things locally applied, sure. And then also for prevention of postmenopausal osteoporosis. So estrogen in combination with progestin therapy should be used in patients who have not had a hysterectomy, otherwise they have an intact uterus. And so they can either receive continuous therapy where they're having estrogens and progestins given every single day, or you may see cyclic or kind of intermittent products, I'll call them, where they'll be receiving, say, estrogens on day 1 through 25. They'll add on progestins in the last 10 to 14 days, and then you may have a drug-free period of, say, 26 to 30, where you'd have that withdrawal bleeding, and then you would start the cycle up again with the medication, with estrogen kind of coming back on. Again, this is why you see those products usually come in cards because you can just say, okay, here's day 1, I'm going to use this one, day 2, and that way the drugs are already kind of combined to where you don't have to really think about it. You're getting your estrogen products on these days, progestin gets added on, and then you have the potentially placebo products. Why do you think they put placebo pills in things like birth control and some of these hormone products? Yeah, so basically so you don't forget like where you're at. And it's easier to get in the habit of just taking a pill every single day, even if it is placebo, because once you're in the habit, you're less likely to forget to, say, start up a new pack. And we'll see that very frequently the most common cause of failure of these, say, oral contraceptives is what? Yeah, user error, basically. So the most common reason why these fail is because people are bad at taking medications on a routine basis. So we will see estrogen therapy used in patients alone with hysterectomy, and then you can also see either continuous or cyclic estrogen, so kind of a similar schedule to what you saw on the combination products. And then you can potentially use low-dose oral contraceptives as a replacement for these, but keep in mind that, and if you're thinking about what we're doing with these products, we're using lower doses because we're just kind of replacing what the body would normally be producing. Oral contraceptives are meant to shut down the system entirely, so those doses are typically much higher. So just keep that in mind that you're more likely to see some of those estrogen-based side effects if you're using low-dose oral contraceptives. So with the oral dosage forms, we know they're going to undergo first-pass metabolism, so it's going to be stimulating those hepatic proteins. We know that's going to be causing more risk for things like cholestasis, for clotting issues. With transdermal products, so these are going to be preferred with women who say have a history of hypertension, increased triglycerides, risk for VTE, or cholelithiasis. So again, by giving transdermal products, you can avoid a majority of those hepatic effects. And then intravaginal products are going to be preferred if patients are only having vaginal symptoms. You can still see some decent amount of systemic absorption, but they are going to have still mostly just having a lot of those local effects. Sometimes you can actually use rings or tablets. Those actually have less systemic absorption, and we'll show you some examples of those products in a little bit. So don't get scared by these slides. You don't need to memorize all of these. These are more for illustrative purposes. You guys already know the estrogens you've already seen. Just remember that list of the different possible estrogen products. This is really just to show you just the variety of different products that are available, the different dosing regimens, the different dosage forms that you might use for patients who are having or a need for hormonal replacement therapy. So notice here we will start out with just the estrogen-based product. So again, imagine a test question could be your patient is say 54 years old. She has a history of hysterectomy and she is having vasomotor symptoms. Which product might be best for her, right? And so we'll give you a list of products and you have to help pick that out. So one might be progestin estrogen combination. You say no, that's not the right one because she's had a hysterectomy, or so be able to kind of discern what might the best product be for your patient. That kind of makes sense? Okay. So you'll see that a lot of these are going to be continuous products. So you'll notice that these are going to be the same dose. Basically, you just end up taking every single day. So it's a continuous versus an intermittent product. Let's see. Nothing else too interesting there. Here you can see the transdermal estrogen products. So you see there's lots of different varieties. This is why there's no point in really remembering the brand names unless there's one specific one that you always will recommend because there's just such a variety out there. You'll notice that a lot of these products, the transdermal products may either give once or twice a week, depending on the dosage form itself. So again, this is useful for patients who maybe have issues forgetting to take their medications. This is nice to maybe just do it once a week, and you'll have continuous absorption of the drug. You can also have transdermal gels and sprays that can also be effective as well. Let's see. Next, you have some creams that can be used. So notice these are vaginal creams that will be directed, that will be administered locally. Again, these are going to be for more local symptoms. So if your patient was having, if you were worried about your patient having risk of osteoporosis, these might not be the best products. Maybe a transdermal gel or maybe an oral product might be better for them, right? So being able to pick out which product is best for your patient is going to be really important here. And notice here, if you're looking at, say, like the conjugated estrogens, how the schedule is going to change based on the product that you're using. So kind of point that out here. So notice, for the first 21 days, you'll take the active drug and then you're off for 7 days, right? And so you just can keep that cycle up. So this would be more of kind of an intermittent schedule. And during that 7-day period where you're not taking the drug, what do you think is happening? Probably withdrawal bleeding, right? So that way you're at least keeping on a consistent schedule. You're not maybe having it at random times throughout the month. So. There's also some rings that are available. So these are basically just usually probably silicone, if I had to guess, rings that have been impregnated with the drug that will have a slow release of estrogens over a long period of time. So notice here you have like the E string. This is really good because it lasts for 90 days. So again, you only have to change the product out every 3 months. That can be useful for patients who maybe have issues with compliance. That can be a big use there. Femring is another one you can use as well. And then also the tablets, notice this would be utilized more frequently. So here you're noticing maybe using one tablet per day for 2 weeks, and then you have a maintenance period where you're just using one tablet twice a week, right? So you kind of use a higher dose up front to really get the symptoms under control, and then you're kind of more on maintenance therapy. So again, that would be better for having just local effects as opposed to having a lot of the systemic issues. Here's an example of what something like an E-string would look like. It has just an intravaginal ring. You basically just place it right in there, I think right around the cervix, and it just kind of sits there and just releases drug over the 90-day period. Whereas with a lot of like the vaginal creams and things like that, usually an applicator that's involved. So basically, you just kind of fill up the applicator, insert it, and then apply the medication. Keep in mind, patient education. Make sure they're cleaning these products off in between uses. Otherwise, that can lead to some issues, maybe UTI, things like that. You'd be worried about. Moving into products that are combinations, so this is where we're now adding on estrogens and progesterone products. Here you're going to be seeing a lot more of the either continuous cyclic products, or you'll be seeing the intermittent. So you notice there's the different dosing here. So for instance, I'll stop. Oh, yes?
So the ones we just talked about were estrogen only, and we use that when they don't have a uterus anymore.
Mm-hmm.
Would you still get withdrawal bleeding? Where's the bleeding coming from?
Well, that's a good question. You probably have less bleeding, but there may be some risk for it, because there may be some residual tissue there that may still be influenced by the estrogen effects.
And we're still not going to do it continuously. When do these women not want to have withdrawal bleeding?
Probably, yeah. So again, it depends on your patient. Potentially, if they're concerned about things like breast cancer risk, total drug exposure, the longer you're on it for, the more that risk is there, right? Okay. So if I was only on it for 3 weeks out of the month, your risk is cut down at least somewhat. It may be small, but at least it's less than. So it depends on your product. If they want something more natural that normally would replicate what their body would naturally produce, at a younger age, that might be better for them. So again, it's a conversation. I think a lot of people end up just getting put on continuous therapy, right? Yeah. But anyway, if you're looking at the combination products here, notice you might have, one period where you're just using 2 tablets, where you have one of just estrogen alone, one with estrogen and progestin, and you'll use the one that's estrogen alone for, the first 2 weeks, and then you add on the progestin for the last week. So just keep in mind, there are lots of different products that are available out there. Here are a lot of the continuous products where you're just using basically the same tablet throughout the entire period. They're just kind of compounded together with estrogen and progestin in the same one. Let's see. Some of the varieties I can see here, nothing too interesting. Again, you can also have transdermal continuous combination products. So they're available as well, especially if you're concerned about liver issues. And then here is the just the medroxyprogesterone. So this is where you'll see medroxyprogesterone is usually the one that's going to be injected intramuscularly. So you can see that available as well. Again, if your patient is contraindicated to receiving estrogen, this is where you'd want to use a progesterone product by itself. Right, so say if I had a test question came up and the patient has high risk for estrogen receptor positive breast cancer in her family, and she's concerned about this, what might be the best product for her hormonal replacement therapy needs, you might use a progestin alone, right? A SERM might be another good option for them as well. Okay, so other medications you can use in order to treat some of the vasomotor symptoms of menopause. So certainly we'll talk about these medications as we move forward into, like the behavioral health section. But antidepressants can be used sometimes. Things like selective serotonin reuptake inhibitors. So can you guys think of any examples of those? Yeah, Zoloft or sertraline, Prozac, Paxil, things like that. So we'll talk about those in probably 2 weeks' time. But SSRIs can be useful for that. You'll also see drugs that are selective norepinephrine reuptake inhibitors, or SNRIs. That's where venlafaxine and desvenlafaxine come in. They work very similarly. We'll talk about the mechanism in a couple weeks, but essentially they can be useful for some of the vasomotor symptoms. You'll see these also being used for things like neuropathic pain as well. So we'll talk about that later. Anticonvulsants like gabapentin have been used previously, and also antihypertensives like clonidine, because again, these are all sympatholytics. These can help to kind of decrease that kind of sympathetic outflow to help decrease some of those hot flashes and things like that. Although I think my mom calls them power surges. I think it's much more positive spin on it, I think. Okay, so that's for hormonal replacement therapy. Next, we're going to move on to the oral contraceptives. One time I was teaching a class for a pharmacy school, and I started it off, it was like a clinical toxicology class, and so I started it off by saying, okay, well, tell me your name, tell me why you want to take the class, and what your favorite drug is. And so people are going around, Tylenol and ibuprofen. I find pharmacy students are usually a lot more kind of shy and kind of introverted, if you couldn't tell. But anyway, I got to this one guy at the very end, and he was just, I don't know, birth control. It's like, okay, that's a pretty good answer. Okay. So for hormonal contraception, so this is where we're going to be using combinations of estrogens and progestins. You'll see that the dosing is going to be variable, right? So we're going to see that in some cases you use a monophasic product, which basically means you're just using a constant dosage of both estrogen and progestin during the menstrual cycle, right? So not really mimicking what the female body would normally do during that cycle. If you can remember going back to that graph, seeing when estrogen kind of peaks versus progestin, that's not really mimicked by the monophasic. As you get into more phases of that, you're going to see that the dosage will change a little bit to try to more closely mimic what a normal female would actually be producing. So you can go biphasic, where you would have a dosage of one or both components being changed during the cycle, or you can have triphasic, where you can end up having two changes during the cycle. Again, for the patient, it doesn't really matter because they're just taking one pill each day out of the pack. It makes it easy for them, but there may be some situations where you might want to use one versus the other. We'll talk about why that is. And then there's also the potential for using progestin-only therapy. Note here, there's no case where for hormonal contraception that you would want to use estrogens by themselves. It's either a combination or you want to use progestins alone. So the mechanism here, as we've kind of mentioned, we're giving large doses of these hormones because this is going to help shut down the pituitary function that is releasing luteinizing hormone and follicle stimulating hormones. So basically preventing that follicle from ever really developing into releasing an ova. So prevent ovulation from occurring by doing that. You'll also see that when using combination products, you can have changes in the cervical mucus, uterine endometrium. You'll have differences in motility and secretion in the uterine tubes, and also basically at the end, this is the big thing they want, is the decreased likelihood of conception and implantation, right? That's a positive thing there. So we will see that progestins don't always inhibit ovulation. So that could be some big issues. You'll see that with progestin-only products, the risk for failure with perfect use is actually a little bit higher than if you're using a combination product. You'll see there'll also be some other issues with it as well. So in general, estrogen plus progestin is going to be a good combination. Progestins you will use in certain circumstances, but there are some drawbacks to using those alone. So as far as other physiologic effects, we'll see with the ovaries, you're going to have depressed ovarian function. So at least very smaller during actual therapy. Most patients end up returning back to a normal menstrual pattern once it's discontinued. And we will see that for majority of women, when they're coming off of hormonal contraception, about 75% of them will ovulate on the first cycle, and then by the third, about 97%. So some may remain amenorrheic for some period of time, but for the most part, majority of women will get back onto their normal cycle. So again, this is good for patients who have an idea of when they would like to get pregnant. This is better for them to use kind of oral estrogen plus progestin, because again by the third ovulation period, they're kind of back to normal. Versus we'll see that as some issues when you're using kind of long-acting progestin products. You will also see in the uterus, you may see some hypertrophy and some polyp formation, and they'll have thicker, less copious mucus that develops there. All of this is kind of helping to prevent implantation of the sperm in the ova. You will see breast enlargement that can occur. This is from the positive estrogen effects on those receptors. It will also suppress lactation. And then again, from the estrogen effects, as you might imagine, you will see increases in factors 7, 8, 9, and 10. You'll see decreases in antithrombin 3 and those are the thromboembolic concerns. So typically, if you see a young female who is having, say, a PE that is otherwise healthy, what's the first question you should ask? Are you on birth control? That's probably one of the biggest links to it, especially those that are smoking as well. It can be kind of a big risk factor. So we mentioned with the estrogens, you can also see hyperpigmentation. So especially if you have dark complexions, if you have a lot of exposure to ultraviolet light, this can worsen that. And then from the androgen effects, you can potentially run the risk of seeing things like acne develop due to that increased sebum production. And then for the clinical uses, obviously contraception is going to be the big one here. So when taken according to the actual directions, so if you had perfect patient use, the risk for actual pregnancy is very, very small. So combination agents, you would see 5 to 12 pregnancies per 100 women years at risk. Sounds like a lot, but that's basically factoring in the patient non-compliance. So if you actually had perfect use, you'd end up seeing it right around half to 1 pregnancies during that time period. So it's not perfect, but it's pretty good. You'll see that anything that can increase the metabolism of these drugs, these contraceptives, or things like antibiotics, which may inhibit the enterohepatic recycling, will limit the effectiveness of these drugs. So this is very frequently where, if you have things that are enzyme inducers, especially 3A4 inducers, we'll talk about a lot of those when we get to the neurology section, that can increase and speed the metabolism of these drugs, making them less effective. So you run the risk of pregnancy there. And then also during courses of antibiotics, there's some theoretical risk of having a failure of the drug. So in those cases, I oftentimes recommend using a backup method of contraception. You can also potentially use it for things like endometriosis. So you may have estrogen being effective by itself to help alleviate some of this pain, but in order to limit the adverse effects, again, you want to use the smallest dose as possible. So looking at adverse effects as other things you might see, usually as the mild adverse effects go, you can normally see some nausea, mastalgia, breakthrough bleeding, and edema. Frequently this is caused by too much estrogen effects, and so you can end up lowering your dose of estrogen and progestin with lower your dose of estrogens to help this, or you can use progestin with more androgenic effects, can actually help to prevent some of these. As far as headaches go, you can potentially have mild and transient headaches, could make migraines worse if your patient's already had that. But keep in mind that because of the pro-embolic effects of these estrogens, if they were to have sudden onset of new migraines when they're taking this, that could probably be a concern, right? Because then you're worried about stroke risk and things like that. So if a migraine coincides with therapy, you probably want them to stop taking it and get evaluated. And then you may see withdrawal bleeding fail to occur when they come off during the normal, say, 7-day period where they're not taking any active drug. This could be causing confusion about pregnancy. So again, we'll talk about when they should probably use a pregnancy test a little bit later. And again, if that is problematic, if they're on the same drug for a period of time, they still have no withdrawal bleeding, they may need to switch over to a different product. Say a different estrogen-based product or a different progestin may help to alleviate some of that and get them back on a normal withdrawal cycle. Again, with some people with more moderate adverse effects, you can see some breakthrough bleeding here. You will see this most commonly with progestin-only products, so about 25% of those patients. So if they're on, say Depo-Provera IM once every 3 months, this can be somewhat problematic for them. You will see this more often in lower dose preparations. You see some breakthrough bleeding. And so what they find is that by using something like a biphasic or a triphasic product, which will naturally kind of ramp up your dose of estrogen as time goes on, you will have decreases in breakthrough bleeding without increasing the total amount of hormone that the patient is being exposed to per month. If you guys look on the Blackboard slide, I put a PDF that has a bunch of different contraceptive products. I'm not going to list them all here in this lecture, but just take a gander at that and kind of see the differences in how the dosing goes between, say, your monophasic versus your triphasic, just to get an idea what that looks like. And then weight gain, you're going to see this more common with androgen-like progestins, and you're going to have this being affected by shifting either to a product with less progestin effect, or dieting can potentially help as well. So if they're having that increased pigmentation, especially for dark-skinned females, this could increase with time. So you end up seeing that maybe 5% of women have this at the end of the first year, but after say 8 years, around 40% of women may have some increase in pigmentation. So this can also be exacerbated by a vitamin B deficiency. So you want to potentially supplement with that, say with a prenatal vitamin, and it's mostly reversible, but it could take a while for that to reverse out. Acne can be worsened, although a lot of people end up taking oral contraceptives for the positive effects on acne that it has. But if your progestin has a lot of androgenic effects, this could potentially worsen it. And so using larger doses of estrogens may actually help to improve that. Right. Hirsutism could be occurring. This is going to be mostly related back to the androgenic effects of your progestin. So again, switching products may help to alleviate that. You also can see urethral dilation, similar to what is actually seen in pregnancy, and so potentially you run the risk of increased frequency of bacteriuria. You will sometimes have vaginal infections, more common and difficult to treat for these patients for whatever reason, and then amenorrhea could also be an issue here as well. So patients who are having menstrual irregularities prior to taking are especially more prone to developing this as well. Could also be related to say like a prolactinoma that can be exacerbated by some of these progestins. And then very severe, this is the big thing you worry about, is going to be venous thromboembolism. We see that patients who are taking these medications, the risk is threefold higher, well, even on a low-dose oral contraceptive. So you'll basically see that the risk is increased during the first month and continues on pretty steadily during the duration of treatment. And then basically within a month of coming off of therapy, you kind of return back to your normal risk for VTE. So risk is really related to the estrogen only. So potentially, say if you had a patient who is relatively young, healthy, they end up developing a clot. Based on this, you can maybe switch them to a progestin only product, right? So it could be one option for them. You also worry about the risk of myocardial infarction in some high-risk patients. So again, this could be increased risk for patients who already have pre-existing diabetes, hypertension, or obese, especially higher in smokers anyway, because again, they are going to be more pro-clotting in those stages. And then you worry about things like increased atherogenesis, coronary arterial spasm, and then you also see that with the androgenic effects of some progestin, you have decreases in HDL. So this one is certainly not super common, but it's something to at least be aware of. Again, another good reason to tell your patients to stop smoking. Again, cerebral vascular disease kind of go back to the stroke risk we see with the procoagulant effects here. Usually you're going to see the risk is going to be more highly concentrated in those that are greater than 35 years of age. With gastrointestinal effects, you can see cholestatic jaundice. We know this is from the hepatic effects of the estrogens. Most often you're going to see this in the first 3 cycles if it's going to occur, and usually it can resolve upon discontinuation of the medication as well. You will sometimes see patients who can actually have their depression exacerbate, especially if it was underlying or untreated beforehand. So, maybe around 6% of patients may actually require discontinuation. So it could be something to monitor for as therapy goes on. And then you have your cancer risk as well. So certainly reduced risk of endometrial and ovarian cancer. That makes sense because we have the progesterone on board. But your lifetime risk, hopefully for breast cancer, appears not to be affected in the long run. So again, something to at least discuss with your patient, say that yes, there is a possibility there, but for the most part, it appears that lifetime breast cancer is not seem to be all that much affected. But for high-risk patients, especially the family history of it, it could be an issue. And then, yes?
So it's protective against endometrial and ovarian, but it can cause cervical cancer?
Especially when women have HPV. So it really just is going to depend on your patient, kind of what the risk factors were for it beforehand as well. So again, if you were to have, say, just estrogens alone, you would end up seeing kind of increased risk for things like endometrial cancer. But because you're having those progestins are on board, kind of keeping things kind of regulated like it would normally be, because as far as the effects on the endometrium go, the estrogen and the progestins are kind of on a balance there. They're kind of counteracting one another. So that's why you're kind of seeing that reduction in that risk. That makes sense? Okay, so this is a good table to kind of compare some of your androgen effects. So again, kind of refer back to this. If you're having a patient who's having, say, some of these adverse effects, you can see where some of the progesterone will have some positive estrogenic effects. You're also going to see the more the androgenic effects you're concerned about as well. Notice this is going to be mostly limited in your drosterone. This is, again, a common one. It's probably a newer progestin that a lot of patients are being placed on nowadays. But things like levonorgestrel, it's very, very common to see being utilized. We'll also talk about some of our emergency contraceptive products and where these fall into play with that as well. So, contraindications and cautions. These are the things you should either avoid in some patients or what to warn them about. So again, if they have a history of thrombophlebitis, cardiovascular disease, or cerebrovascular disorders, again, be cautious for those patients. Any unknown cause of vaginal bleeding should be checked out prior to starting any of these products because, again, it could be cancerous, it could be anything that you want to get checked out first. Any history of estrogen-dependent tumors, you probably want to use progestins only, right? So again, it could be a good test question. Patients who have a history of heart failure, some of that progestin effects could end up worsening that, especially with fluid retention and things like that. Adolescents who haven't undergone epiphyseal closure, why do you think that's a problem?
The estrogen is still big from all the physical closure.
Yeah, so the estrogens are causing that to close in the first place. So again, if they have not really had their full amount of growth occur, you may close those too early, end up having a shorter stature than you would otherwise. Hepatic enzyme inducers. So we'll talk about things. You guys remember rifampin? What type of drug is that? is a TB drug. Sometimes you'll see it used for endocarditis, right? So that's a potent enzyme inducer, especially things like 3A4. Phenytoin, which is an antiepileptic we'll talk about in a couple of weeks. Why do you think enzyme inducers is a problem here?
Changing the rate and amount in your body because it's doing it faster.
Yeah, it's metabolizing the contraception faster. So again, you're going to have lower levels in total, increased risk for failure, right? So again, you don't want to set your patients up for failure of this, especially when it could be a potentially very expensive, very long-acting side effect. Only 7 months in, but love that baby. Just kidding. Certain antibacterials, because you have concerns with interrupting that enterohepatic recircling or cycling of the drug. Because you remember we said the estrogens get kicked out through the biliary tract, they get hydrolyzed there and can be reabsorbed. So again, the duration of action is much longer than what the natural half-life looks like because of that. So again, if you're giving things like antibacterials, there's some theoretical risk that you're interrupting that could potentially have failure of the drug. So again, I usually recommend backup forms of contraception whenever patients are on a course of antibiotics. And then, obviously, if they're already pregnant, you don't want to put them on these contraceptive products. Again, sometimes you may not know if your patient's pregnant or not, so that could be one thing to at least discuss with them. So, progestin-only contraception. Oh, yes?
For patients that are on, for acne, how they use combination therapy with antibiotics. If they're using the hormone therapy for to not get pregnant, and then they're using the antibiotics for the acne, do they always have to use backup, for cases like that?
That's a good question. I hadn't thought about that specifically. I would think that at some point you would probably get to kind of a steady state, if you're constantly, and usually you're not using treatment doses of a lot of those drugs, right? So hopefully you're using lower doses of the antibiotics, so you may not see as big of an effect. It's a conversation to have with your patient at least, where you can say hey, there's this theoretical risk that you could have failure. Talk about compliance. Do they actually take the drug every single day that they're supposed to? Is there any risk of using backup? Probably not, but there's also prevention of STD spread and things like that. So there's other benefits to using backup contraception, but it's a conversation to have with your patient. Yeah.
For the previous contraindications, are those for combo products?
Those will mostly be for the combo products to see that if they have thromboembolic issues, we'll see that using a progestin can get around some of that. So it's mostly for the combo products. Yep. Yes.
What did you say to use for the heart failure?
Oh, so for if they had heart failure, you'd probably want to use things that have kind of fluid neutral properties. So you don't want to use something that has high mineralic corticoid effect. So using something like drospirin is always my go-to one. It kind of limits the amount of kind of fluid retention you end up developing, and so that can kind of help with that. All right, so for progestin-only therapy, so this can be suitable for patients that estrogen alone or estrogen in combination with progestins are not going to be recommended. And so they're nearly as effective, but again, we're talking about pregnancy, nearly, I guess horseshoes and hand grenades is the only place where close counts, right? So again, can be mostly as effective, but again, you always want to have those conversations. But you will see higher incidence of abnormal bleeding. Usually this will decrease with time, but you will see that amenorrhea is fairly common when using progestins only. And you will see a delayed return to ovulation. So if your patients say hey, I'm not planning on getting pregnant for years to come, this might be an okay thing. If you want to give them an IM shot of Depo-Provera every 90 days or so, that might be totally fine for them, right? But they're well, I'm trying to get through school, or I'm trying to get through whatever, in say 6 months, maybe I want to get pregnant. That might be a thing where you might want to avoid some of these progestins because it could delay the time back to getting to normal ovulation. So other things to consider, so post-coital contraceptives, these are the morning after pills. Again, do you need a prescription to get these anymore necessarily?
No.
Yeah, so that's a big law change that happened several years ago, where now you can just kind of go up to a pharmacy and acquire Plan B, as they call it. So you will sometimes see these either being estrogen-based products, progestin only, or a combination. You will see that when given within 72 hours, they are going to be 99% effective. And so these are very, very big doses. We see that if you look at the oral contraceptive comparison chart, you'll see that usually these doses are in micrograms per day. Notice here, like for the levonorgestrel, it's a plan B. You're going to be given, say, like 1.5 milligrams. So it's a lot bigger dose. Hopefully the idea is you just kind of just, whatever's there, what might be implanting, you just kind of slough off whatever endometrium is present and go ahead and just get rid of that pregnancy, potential pregnancy. So again, very effective when used within the first 72 hours. And you oftentimes want to administer this with an antiemetic because there's a high propensity for having nausea and vomiting associated with it, which could necessitate them taking the medication again, right? So if they take it within, say, at 9 o'clock and then by 9:30 they end up throwing it up, you probably want to retake that. Usually after an hour or so, you can be assured that they've had enough absorption of the drug. But again, it could be one of those things where might need an additional dose to replace the one that they might have thrown up. We're going to continue. I had a very good question that came up that I thought I'd mention here so everyone could get the benefit of it. Someone said, what happens if someone accidentally gets into birth control? So say like a toddler accidentally gets into mom's birth control, starts popping them out, taking them, like Tic Tacs. Is there any problem with that, do you think? Yes? I think it's a problem. It's hormones, right? So working at the Poison Center, you get lots of fun phone calls. And so this is one of my favorites where a dad called up. He was very, very concerned. He said his 2-year-old son had just gotten into his mom's birth control. He said, is he going to turn into a girl? And I said, sir, chances are your child's going to be fine. But if he wants to go shopping over the next few days, just indulge him. He didn't get it. He was like, what? I'm like, I'm just kidding. He'll be fine. Yes. So accidental exposure to especially some of these oral contraceptive products is okay. They're not going to have any long-lasting effects. I'm not even aware of any kind of short-term effects, really. So it's a very safe thing if they were to accidentally get into it. So no problems there. But I thought that's a very funny phone call. So anywho, so other benefits of oral contraceptives include reducing the risk of things like ovarian cyst, reducing ovarian and endometrial cancer, especially in high-risk patients. It can reduce your risk of things like ectopic pregnancy. Can actually help with like iron deficiencies and whatnot. And then also rheumatoid arthritis is purported to be one risk that is reduced there. You can also have positive effects on things like endometriosis, acne, and also hirsutism. Again, you worry about things like androgenic effects of some of your progesterones that can actually worsen that, the acne and the hirsutism. So just be aware of that. If that's getting worse, you can switch over to a different product that has less of those properties.
How does it reduce the risk of rheumatoid arthritis?
I don't know. It seems to be one of those things where they had, it's one of those things where they look at a bunch of women and they say who had rheumatoid arthritis, who doesn't, and they look back to see what their risk factors were, and this appeared to be one of the protective factors. So, yep. Okay, so oral contraception in general, when you're starting them out on a patient, you want to start with the combination pill unless they have some sort of contraindication to receiving estrogens. You want to use the lowest dose possible, so looking at things between like say 30 and 50 micrograms of the estrogen-based product. You need to kind of figure out what an acceptable level of side effects are going to be, let them know what the warning signs are, if they were to have, all of a sudden signs of a VTE, or if they were to have sudden chest pain, things like that you should be worried about. Typically want to give them like a 3-month supply so that way they can at least get started and they can at least kind of assess what side effects will get better with time, which ones are going to be sticking around, and then you can kind of decide whether or not you need to change the dose of the estrogen, change the progesterone you're using, or use a different product, something else entirely. Keep in mind, some products are designed to last for long periods of time. So, if you're looking at something like, say, an orthotricycline that's working, it's a tricyclic product or a triphasic product that's working for 1 month at a time. How do you think that differs from a product like Seasonique that's meant to be taken for, say, 3 months at a time? What do you think is the difference between those products?
Skipping the placebo pills.
Yeah, so essentially what's happening there is you're actually skipping the placebo pills in the Seasonique. So there's a couple different products that are like that, but basically you're just taking constant estrogen and progesterone for a long period of time, and say after the end of the 3 months, or some cases I think they might even go like a year long, they'll have that withdrawal period, right? And then you kind of get back on the new cycle. So again, depending on your patient, they may like to prefer, say, I only want to have 4 periods a year versus having, say, 12.
Have there been any risks shown to doing that?
I've not heard of anything specifically because, again, most of the time they're taking estrogens and progesterones together that are kind of counteracting one another. So I don't know if there's any big risk associated with that.
But if there's like 3 months where you're not on your cycle, then isn't the layer building up?
Not necessarily, because the progesterones are kind of there to help prevent a lot of that buildup. Yeah. Yep.
Are the menses heavier when they do come around?
I don't know if they're actually heavy or not. That could be one thing you might see, kind of increased bleeding as being a side effect. So for some women, they might be more prone to have that than others. But any other question?
So could this technically prolong fertility if they're not ovulating anyway times?
I don't know. That's a very good question. You'd ask Dr. Nicholson that next time she is here. Yeah, I'm not sure, because, again, if you think about it, maybe I was like, okay, I have an extra, year of fertility on me, so maybe you get pregnant, from 39, say, to 40, or whatever happens, so that's a possibility, who knows. But I don't think anyone's actually asked that question. You can do the research maybe and find out. Okay, so anyway, lots of different products are out there. Look at the chart. You can kind of see what some of the different flavors, so to speak, can be that you can utilize for your different patients. There's a million different brand names, a million different products. It's too exhaustive to even to list here, so that's why I just give you a PDF you can look at. So how you should start oral contraceptives. So normally you want to start on the first Sunday after menses. So we start on Sundays. Why?
First day of the week.
First day of the week. So this actually avoids withdrawal bleeding on the weekend. So if you imagine if you start on the first Sunday, you're taking it for 3 weeks, you kind of start your placebo pills on that Sunday, and then you have your withdrawal bleeding during that week, and then so by the weekend you're kind of back to normal, right? So that's why they end up giving it on Sundays, to avoid that weekend. Because again, most people are out doing things, they're not at work or school or whatever, so that's when they like to not have their period. As far as pregnancy goes, for 3 to 4 weeks post-delivery, that's usually when they can start them back up on that, especially if they're not breastfeeding and whatnot. And then if they were to have had an abortion, usually they want to start the first Sunday after that abortion to kind of reset their cycle at that point. When you should use alternative forms of birth control. So if they're using the initial cycle, this is kind of controversial, but some people will recommend using backup just in order to help get the patient kind of on their new normal, so to speak, while they're on the contraceptive. And so some people will recommend that, but it may or may not be necessary. We'll talk about missed pills and how you can kind of catch up for that. We'll talk about that regimen in just a second, but especially with low-dose regimens, low-dose estrogens, because those are kind of at a higher baseline risk anyway, some people would recommend using backup then. If you would have severe diarrhea, you may not be getting as much of that enterohepatic recycling that you would normally see, and then also with antibiotics. So again, it's one of those things where it's not concrete, there's not concrete evidence that says you absolutely have to use backup here during the situations, but there are things to consider.
Patients with like Crohn's disease and things like that, can they use oral contraceptives? Is it going to be as beneficial for them as a normal person?
That can certainly be an issue. If it's known that they're going to have kind of very consistent kind of diarrhea, that may be a good option for either using like an intrauterine device or utilizing a shot or something like that may avoid a lot of those issues. Yeah. So what happens if you have a missed pill? Because this is definitely a question that might come up. So your patient calls up frantic. They said, oh my gosh, I forgot my pill yesterday. What do I do? If you are using combination products, again, this is specifically for combination products. If you have a single missed pill, have them take it as soon as they can remember, right? If they miss 2 pills, they can end up taking 2 pills for 2 days to catch them back up, okay? They're still fine. They can still, you don't necessarily need to worry about using backup contraception. That should get them back on track. Now, if they miss 3 or more days, most of the time you're going to recommend that they just discontinue the rest of the pills and just restart on a new Sunday. So just throw that pack out and then restart on the next Sunday.
So if they're taking 2 pills for 2 days, they take it from the end of the pack, and then they finish early?
No. So they will. So if you miss 2 days, so for the next 2 days, you're going to take. You kind of make up for those doses, so then you're back on the normal schedule. Yeah, absolutely. And obviously, if they get down to the placebo pills, then it doesn't really matter at that point. They miss 3 or more, then that's probably a good reason that your risk of failure is high enough at that point. You just want to discontinue it, throw it out, and just restart on the next Sunday. Right? Make sense for everyone? I'm surprised I'm getting the most questions from females. The guys must know this stuff already and pretty well versed. Okay.
Not their problem.
Yeah, not their problem. Wow. Guess we're going to be providers. You have to care about all your patients. Okay, so for missed periods, so if they have a failure or withdrawal bleeding, what's your first concern?
Pregnancy.
I'm pregnant. Okay. So if they've had no missed pills, if they've been very consistent with taking it, you can take a pregnancy test, say, after the first one. Usually your body's just trying to kind of catch up and get used to the new products that are on board. And so with the first missed period, you don't necessarily need to jump to taking a pregnancy test. Probably a lot of people will be nervous enough they want to take one anyway, but you don't necessarily need to recommend it until maybe the second one. If you wanted to reschedule the menstrual cycle, this bewildered me at first. I was just like, "What, you can reschedule that sort of thing?" Like, I thought this was ingrained into your DNA. You can do it though. You can absolutely do it. So you can do, this is kind of called the honeymooning method, to where if you know you have like a big event coming up, or if you have something where like, I do not want to have my period during this time frame, basically what you can do is just continue taking active pills until the special occasion is passed, and then you can kind of basically have your week of placebo, and then start a new pack. Or tell them not to take anything for that week, and then they'll have their period, and then you can start a new pack. So basically you can kind of reschedule things around to where they're not going to have their period, say when they're going out to the Bahamas for their honeymoon. Well, think about it. I mean, some of those products you can take for 3 months at a time and not have a period, and that's okay, right? So this may just be for, say an extra week or whatever happens to be, you're not having that. So really no big adverse effects you'd expect to see from doing this. If you are looking to stopping the pills, basically as far as rest periods go, there's really no need necessarily, but for if you have a desired pregnancy, typically you're going to see 3 regular cycles prior to conception. Again, that kind of gives time for ovulation to actually kind of get back to normal for those patients. So just keep in mind that you don't need to taper down doses or anything like that. You can just DC the medication and kind of get back to normal. But they're expecting to get pregnant. Let them know that it may take a few cycles before they're going to be back to normal. If they are having breakthrough bleeding, so especially during the first 3 months, this is why you kind of prescribe them 3 months in the first go. This generally resolves over time as their body gets used to those estrogens being around. If it's still present, you can manipulate the pill based on the location of the bleeding during the cycle. And so this is kind of interesting to where if they're having bleeding early on in the cycle, say in the first 1 to 14 days, this is usually indicative of an estrogen deficiency. So it's maybe one of those things where you actually want to bump up their dose, from 30 to 50 micrograms per day in order to help eliminate that breakthrough bleeding. If you are having bleeding later on in the cycle, say 15 through 21 days, usually that's going to indicate a progestin deficiency. So you may need something with a little bit higher progestin activity or a bigger dose. So that would be the one thing you want to look at. So again, if they're having breakthrough bleeding, ask them when it's occurring during the cycle, and then that way you can kind of better diagnose how to fix the problem. Okay. Then we mentioned having the shot, the progestin only shot. If you think about it, it's kind of interesting. My wife was asking about this. She's like, really, birth control is the only thing you call the pill, right? Like if you're having a heart attack, you don't take the pill, you take aspirin. Just like this is the shot, There's actually there's an interesting article she ended up finding based on this, and I guess it was during the 1960s and when birth control first came out, and it was this huge liberating thing for a lot of women, not only those who were single but also pregnant or married females who wanted to have that kind of liberation, not worrying about getting pregnant all the time. So this is actually a big thing, and so it was kind of a big shift for a lot of women. So that's where it kind of got that moniker of the pill. So it's kind of interesting historical point. But anywho, with medroxyprogesterone acetate or Depo-Provera, so notice anytime you have Depo in front of a drug name, that usually means it's an IM shot meant to last a long period of time because it's kind of forming a depot of drug that you absorb slowly over a period of time. This one's going to be injected every 3 months. It's good for 90 days worth of therapy. And usually you're going to see that even if you stop therapy, the duration of effects is going to be about 4 to 6 weeks longer than just even the 3 months. So that makes sense why they may have amenorrhea for a longer period of time, to where it takes longer for them to get back into a cycle where they're going to be ovulating normally. And they can also have kind of very irregular menstrual bleeding patterns, especially because they're not really having an estrogen effect around. This is only progesterone that's really doing this. But for patients who are really poorly compliant, so I'm going to mention a patient who is, say like in a psychiatric ward or had significant issues where they may be highly promiscuous and you are worried about them actually taking things like oral contraceptives, like this may be a really good option for them. It's a good long-term therapy where they can kind of keep themselves out of trouble, so to speak. So just take your patient factors into account when you're deciding what product to use. Okay, so there are certainly some miscellaneous products you can use as well. So for instance, this is Mirena, which is a intrauterine device. So if you're IUD, it's not IED, very different type of thing. But IUD is intrauterine device you can apply, and so these will last for long periods of time, and really you don't really need any kind of withdrawal period for these. They just kind of stick around for a while. So Mirena, which is levonorgestrel, which is a progestin only product, is going to last for about 5 years. So basically, it gets implanted there. Sometimes these will end up being kind of sutured in place. Sometimes those sutures can fail and they will actually come out early. So just be aware that these need to be applied by a provider. This is not something the patient would do themselves, right? You also have the NuvaRing. This is a patient-applied product, so this is one that would be more simulating a normal type of oral contraceptive product. So again, this would be 3 weeks in, 1 week out. So this is good for patients who have poor compliance. You can see it's kind of a bendable one. They can just apply it, kind of set it around the cervix, and it just kind of releases drug slowly over that 3 week period. I thought this was a very funny picture. Niva bling. Okay, other ones you can see, there are some implantable products that are good for longer periods of time. So this is a etonogestrel or Implanon. This one is going to be implanted underneath the skin every 3 years. So it can be a useful product there. Again, you'll end up seeing more irregular bleeding due to just having the progestin only effect there. And then there's actually a copper-based product as well. This is kind of interesting. This is Paragard. This is an intrauterine copper contraceptive. And so this is actually a slow-releasing product that will release copper ions that actually impair the implantation of sperm or transport of it and fertilization. So this one is actually going to be changed every 10 years. So again, if you're not planning on getting pregnant for a long period of time, this could be a good option for those patients.
When you take it out, how long does it take to get back to normal?
That I'm not sure. Not sure, but usually this is for, the people I've seen on this have been like married females who are, they've had their kids, they're kind of done. They're like, okay, I'm just going to take this basically until menopause kicks in. That's the most common one I see. It's not like, for younger females who may be looking to get pregnant a little bit later on. But it depends on, what the situation is.
How effective is the copper versus the Mirena?
I don't know comparatively how effective they are, but both are going to be, similarly pretty good at preventing pregnancy. But again, you also don't have to worry about the patient factor. You don't have to worry about patients not taking it because, again, it's been implanted. It's there. Unless it comes out early, you should be good to go for the most part. Yep. You also don't have to worry about things like, antibiotics or diarrhea. So it could be good for like that Crohn's patient, who's having, you worry about oral absorption of the medication or that enterohepatic recycling. Yeah. Right. So they're not going to ping any metal detectors in there at the airport though. So it's good to know. Okay. So we'll also have some inhibitors and antagonists. So we will look at some medications that will be working as estrogen. We'll look at the selective estrogen receptor modulators. Some of them will be working as antagonists in certain tissues, agonists in other tissues, and we'll see what the benefits and drawbacks of those medications are. We're also going to see some drugs that will work to kind of shut down this hypothalamic axis in order to help eliminate things like estrogen production and whatnot. So these are good for things like cancer, right? We'll also look at drugs that inhibit things like aromatase. This is an important enzyme that is used to convert things like testosterone over into estradiol and other estrogen-based products. We'll look at some different products that work specifically on this pathway. So the first thing we'll look at is the selective estrogen receptor modulators, or SERMs. The first agent we had out there was tamoxifen or Nolvadex. And so this is a competitive partial agonist, an inhibitor of estradiol. So you see that it works as an agonist in the bone and the endometrium, but as an antagonist in breast tissue. So where do you think the main place you see this being used at? What indication? Maybe postmenopausal. What else? Yeah, breast cancer would be the other big one, right? So this is really kind of a huge deal when it first came out because it worked as an antagonist in the breast tissue. So if you had patients who had a history of estrogen receptor positive breast cancer, this is a big deal for them because it helped to prevent breast cancer from occurring in the first place. So again, we don't really know the full mechanism. It could be issues of recruitment of various co-regulators once it's in the nucleus. And again, based on the different heterodimers of what type of estrogen receptors it was binding to there, causes the different effects. So you would sometimes see it used for palliative care of breast cancer in postmenopausal women, or for prevention of breast cancer in high-risk women. And again, this is nice because instead of giving something that would eliminate all estrogen effects in the body, you still had some positive effects in the bone. So it could still be good for patients who are older that you're worried about osteoporosis in. Now, if they still had a uterus, though, this is a problem for them because they had increased risk of endometrial cancer due to those pro-endometrial effects that you saw from this. So this is an oral medication, so it's good for that purpose. And then you end up seeing, because of the antagonist effects, hot flashes and vomiting in a significant number of patients. This is really kind of the first term that it really came about. You also saw that in studies that it was able to show reduction in or prevention of loss of lumbar spine bone density. We know that this is a very huge issue for a lot of older females, and once they have a vertebral fracture or hip fracture, this is usually in some cases a death sentence for them, because they are very much less active afterwards. They are just at increased risk for all kinds of different morbidities. So this is a big deal. Also saw some improvements in lipid changes, and then related to the partial agonist activity, as we mentioned, you would still see the endometrial cancer risk, vaginal bleeding, and then you also see some positive effects on the liver to increase thromboembolism. Okay, so this is the first drug that really came out in this category. It wasn't the best one. We'll see there's some others that kind of replaced it. Anyway, moving on, then you have raloxifene or Evista. This one is going to be a partial estrogen agonist-antagonist. So again, depending on the tissue you're at, you'll have different effects. So in the lipids in the bone, you're going to have pro-estrogenic effects. But here we're going to see that it does not stimulate the endometrium or the breast tissue. So it's an antagonist in the endometrium and in the breast tissue. Here you're also going to see it being used for prevention of postmenopausal osteoporosis and also prevention of breast cancer in those high-risk patients. So it's the main usage you're going to see there. Another drug called clomiphene or Clomid is an older partial agonist that actually binds up hypothalamic estrogen receptors that helps inhibit that feedback loop. This one is actually a drug that helps to induce ovulation. So if you ever heard of patients who are having issues becoming pregnant and they end up going to like a reproductive endocrinologist, someone like that, like you might oftentimes see them being prescribed clomiphene to help kind of kickstart and start the ovulation process. That makes sense, because if you imagine if you're blocking up those estrogen receptors, it's going to start to, your body thinks, hey, there's not enough estrogen around, let's start kicking out some more FH and LSH in order to help stimulate ovulation so we get more estrogens, right? That makes sense? Okay. A couple other drugs you may see as far as estrogen antagonists go. There's danazol or danacrin. This is a weak progesterone androgenic and also has some glucocorticoid effects. So this one is mainly used to suppress ovarian function. This will help to inhibit mid-cycle surges of LH and FSH. Mainly you'll see it used to treat endometriosis. Usually those patients will end up showing benefit, say 3 to 12 months after starting therapy. And it can also be being used for certain hematologic or allergic disorders. So you may see it used for things like ITP or idiopathic thrombocytopenic purpura, hemophilia, different things like that, because they help to kind of stimulate factors for those. As you might imagine, because it does have some androgenic effects, the glucocorticoid effects, you're going to be seeing things like edema and weight gain, hair growth and whatnot. So it's not used super frequently, but it is one drug you may see out there being used for these purposes. Okay, and then you have the aromatase inhibitors. As we mentioned, this is an important enzyme that converts a lot of those androgens over into estrogen products. So big ones here include anastrozole or Rimidex. Again, this is going to be preventing production of new estrogen. And so this can be useful for patients who, say, are resistant to something like tamoxifen or raloxifene. If they're still having issues with the breast cancer, they can end up giving this, because this will basically shut down all estrogen production whatsoever, right? And so, as you might imagine, the side effects being very similar to what you'd see in postmenopausal women, so vasomotor symptoms and whatnot. Other drugs that can do this as well include letrozole, exemestane. And so you'll have fewer pro-estrogen issues in tamoxifen, but you're also going to have the most risk for fractures, because there's not enough estrogen around to really prevent that bone loss. So these are going to be more for refractory patients where the SERMs are not going to be appropriate for them. So, any questions on the OB-GYN stuff? Yes?
With those last ones, could you then, since it's preventing the conversion to estrogen, could you then supplement them with like a low dose of estrogen?
Well, for those patients, you're typically giving it because you don't want estrogen around, right? So if you imagine like those high-risk breast cancer patients, or someone who, or say is on palliative care for breast cancer, like you're trying to get rid of the estrogen effects on the breast tissue totally. So yeah, you wouldn't want to do that. Okay.